in this trial, only 27% of patients had a germline BRCA mutation. And for these patients, we already have Olaparib available. So this is just, I think, really good news for this group of patients with quite high-risk disease. And in fact, for this group of patients, the 4-year overall survival was 90%. So that's really good. A question, however, there is, at the moment, Olaparib is only registered for patients who did not achieve a pathological complete remission after third-generation chemo. Well, in our study, we also administered 1 year of Olaparib to patients who had achieved a pathological complete remission. So now, I think one question is, what is the outcome of these patients nowadays in real-world data when they have achieved a PCR at really high-risk disease, so stage 3, but of course these patients only received carboplatin-containing chemo and no Olaparib. Will that result in the same 4-year survival as we observed in SUBITO? Because in SUBITO, and that I forgot to mention, in SUBITO patients, 40% of patients achieved a PCR, and for those patients, the 4-year overall survival was 97%. And it was 97% in both arms. So, well, almost 100% cure. And because we know that these tumors tend to recur early, within 4 years, I think we can safely say that this is almost the percentage of patients cured. So the question is whether the patients who achieve a PCR and have stage 3 disease, whether you also have to give them Olaparib for 1 year to be able to achieve a 4-year survival of 97%. I think that's an outstanding question. We don't know. And we have to get these data from real-world data. The other question is how can we get a PARP inhibitor available for those patients who do not have a germline BRCA mutation, but do have an HRD tumor? Because for these patients, we do not have PARP inhibition available in the adjuvant setting right now. So, yeah, I think we have to discuss this with companies, how we can move this forward, but maybe also with regulators, because what we could do is use a external control arm derived from real-world data, and actually we are doing this right now. So we are using the Dutch Cancer Registry, and we are retrieving all the data from patients with stage 3 triple-negative breast cancer. We are recollecting all their tumors and testing whether the tumor is HRD or not. And so then we will have an external control arm of patients who in fact also received third-generation chemotherapy with carboplatin, but no Olaparib afterwards. And then we can compare the so to say optimized control arm of SUBITO with an external control arm derived from otherwise similar patients from real-world data. So that's something that we will do, and I hope to present those data in the near future. And now the other question also is, of course, intensified alkylating chemotherapy with autologous stem cell rescue is perceived as a really toxic regimen. Interestingly, during the trial, there were patients who in fact went through that treatment very well. And if we look at the quality of life data in the 2 treatment arms, in fact, they were similar between the 2 treatment arms up to 3 years after surgery. And these data were based on the summary scores from the ERTC QLQ questionnaire, that is a well-known questionnaire. So the other thing is that I think that in fact some patients might be better off with the intensified alkylating regimen, because that treatment only takes 16 weeks, while the treatment with Olaparib takes 1.5 years. So I think there's also something that maybe would be very interesting to further explore. Who are the patients that in fact tolerate such an intensified treatment quite well, and then maybe they would be better off with a short and intense treatment.